It's off exit 10, presented by Capital District Sport and Fitness.
Since Jordy's been like, it's, not really stressful at all, other than one time.
There it is. Comes up every time.
Oh boy.
I won't. But I won't say it. I won't bring it up.
What happened?
Yeah, but you have to tell Sam. Okay.
Yeah, what happened?
Jordan.
Start it off, Jay.
Go ahead, Dre.
I won't say which guest because I don't want them to feel disrespected.
Okay,
but we
fair.
did a full, probably hour and a half conversation. Really good conversation. And it wasn't until like Mike said, "Okay, like bye, thank you," I looked down and realized I never pressed record.
Oh shit.
And Jordan, you
Did you tell the person?
No. I shook his hand, said thank you, and then as soon as he left, I told him.
As soon as he left, I look over. Jordan's just sitting over there, and he's like, "We're like, dude, what's up?" He's like, "I never pushed record." Luckily, we had the camera going, so we were able to makeshift it out of it, and it worked fine. But,
Oh man.
and knowing Mike, that was a quick. Oh shit. And then there was me being the balancing act between Mike and Jordan.
Thank you, Paul.
Are you like that with work, Sam? Like, because PT, I feel like we're so customer service heavy. It's like you're just dealing with personalities and people and their needs, and you have to communicate and help them reach your goals. Is it hard for you to shut that brain off when you're not at work?
Yes. I would actually say becoming a parent, which maybe I was like, we should talk about this. I don't know if it's different for you. I genuinely feel like becoming a parent almost helps you because you're kind of forced to shut it off a little bit more, right? Like you walk home and you're like, well, now I got to deal with like toddlers and this and bedtime routine and all that stuff. So that definitely helps. I was pre-kids though, like that was my life. Like even though I'm not an owner of the PT clinic, it's like Clifton Park has been my baby for almost 10 years now, So yeah, I can't shut it off. And I'm constantly like, just today, I was just leaving, I'm giving a patient a running progression and because of his schedule and my schedule, he can't see me the next couple of visits. And I was like, it's fine. I'll give you my cell phone number and like, you could just text me. And he's like, you really don't mind if I do that? I'm like, no, everyone in the Capital District has my phone number. Just like take it and we'll text and we'll figure it out. So, yeah, but I think it comes down to like caring. Like you just can't, you don't know how to like shut it off. So it's probably a good trait and probably like a terrible trait at the same time.
I think it's what makes us good at this and like these healthcare fields. Yeah, but also can like if you're a type A person, you're like super empathetic, it like can deplete you so quick. But the kids thing is real because I definitely get like less worked up or like just think about stuff from in here at home way less. Probably because like the shit doesn't matter as much.
Yeah, well, and it's probably not a conscious effort. It's literally like, oh, like I can't think about or like worry about that right now because I have to like feed my child or, that kind of thing. But yeah, I think you do realize like, okay, life goes on. You can't control everything. I think too, we always joke about how like type A we are.
Mm-hmm.
And maybe you differ. I don't know. Are you super type A or type B?
Paul rides the middle nicely between me and
okay,
Dave.
In the middle, baby. Right in the middle.
Okay. I feel like becoming a parent made me way more type B. Like I used to be that person, like I probably for 7 years straight, I did not leave work on time one time. Like me leaving 15 minutes late was like considered like good, right? Getting to work, if I wasn't there 15 minutes early, I was like bugging out, right? Then you have kids and you start to kind of be like, well, I could roll in right at time. Or a lot of times leaving, you're like, no, I like have to leave because I have to go get my kid. And I feel like you just get to be a little bit better about like rolling with the punches. So probably some people that I work with would say that's been a good character change on my part to not be so like anal about everything.
Yeah, I think it's a good thing. It's I feel it all the way. Like I feel like my mental health, everybody's different with sleep, but like just kind of how I balance my day to day is way healthier.
I feel like you've even said many times that your sleep has been better. Even obviously, maybe not at the beginning with a newborn.
Oh, it's been better all throughout. Shout out to Sam for that.
Yeah, taking care of babies. Woo woo.
Taking care of babies plug.
But I feel like Mike would like not sleep half the time when he didn't have a kid, and now like he's like, oh, I need to sleep because I got to be able to function for Sia and everything. So
it's that, and it's because D was like when you have, before you have the kid, text Sam about this sleeping
I
course.
remember her saying that she's like, you need to like pass along. But I tell everyone because like people be like, what did you do? I was like, no, I didn't do this. I just followed. You probably did the same thing. You just followed exactly what that lady told you to do. And then you're like, bam, my kid sleeps through the night and now I sleep and everyone is happy.
It's amazing. You get a blueprint and you follow it and it works.
Yeah, that's awesome.
I love that.
I like to be coached, so I'm just like, tell me what to do.
Same, exactly.
That's like Jay.
What's the blueprint? What's it called?
It's called Taking Care of Babies. It's a sleep course.
But Cara is like Cara.
It's her name.
Yeah.
I
Nice,
don't know. They
nice
have,
little clever play on words there. I like it.
yeah, I don't know. It just creates structure. It creates routine.
Yeah, when you learn it too, you're not like this. Like you're like, oh, duh, that makes sense. But you're also like, if you didn't do this, I'd be like, I don't even know what we would have done with our child when they were born. Like, no clue. Wouldn't have known anything.
Yeah. I like the structure. I'm a structured person.
yeah.
So yeah, taking care of babies. But Sam, I appreciate you coming on.
Yeah.
You were like one of the first people that I connected with.
I
moved
know
back
when you guys
here.
opened, I was thinking about that.
Yeah, we did like some.
You did like a little opening thing with I invited some patients. You guys had some clients here. We did a talk. I was trying to even think about. I'm like, I don't even remember. I remember taking a picture. I remember what I wore. I know I put together a PowerPoint. Don't even know what it was about. I think it was very general, but yeah.
I don't remember what I talked about either. I know it was like over there when we had the wall up and projected on the big white wall that was there.
Yeah.
But yeah, I don't remember what any of us talked about. But yeah, I just did like a Google search of PTs in the area because in Boston, when I worked, creating connections with PTs was huge. It's how you could help more people. You could create good referral sources. It could help, us grow our business initially. Yeah, and then I found that you went to Springfield, and I was like, oh, no shit.
Yeah,
Dan
you're
and I
like,
went
well,
to-
she can't suck that bad, right? If she went there.
Springfield was so did you do the one shot straight through
I
PT
did,
program?
yeah. So full 6 years. So you apply as like going in, you apply as a freshman to be like, okay, I want to be in pre-PT, they call it. And it's 3-year undergrad. It's a little weird at Springfield though, because then you still graduate with your graduating class, but you're like a year into the doctorate program at that point. So that's weird. You have like so 4 years, but it's really you did undergrad in 3, and then the doctorate program's 3 years. But people think like, oh, that's nice. I'm like, well, you still do 4 years worth of coursework in 3 years.
Right.
And then the doctorate program, you're doing like a couple summers. So you had the summer between junior and senior year, that was the start of the doctorate program. So that was a really tough transition though, because senior year, you probably loved your senior year, right?
Mine was unique
It was?
because I finished my coursework first semester of senior year. Because
Okay.
exercise science, you have to do one big 450-hour internship. So I did mine at Cressy's outside of Boston. And Sam, my wife, now she was in grad school at the time in Boston. So
Okay.
I finished my coursework first semester senior year and then
And
left.
then you were gone.
Gone.
Okay.
Did that
okay.
internship, came back for graduation, got like super drunk one night, hungover, did graduation, and then that was it.
And that was it.
Yeah.
Yeah. So when you start the doctorate program in that summer, you're like adjusting to like, oh my God, this is a doctorate program. And most people, their senior year is pretty like chillax, right?
Yeah.
Like you're doing some internships,
I liked
right?
mine so much I stayed an extra semester.
Jordy?
Right?
Me too?
Right?
Me too.
Yeah. You went to Cortland?
Yes,
Yeah.
both of us did.
Oh, okay. Okay. Yeah. So you like lived it up your senior year. And I just remember being like, well, this frickin' sucks. Like we could never, I don't know. We lived in a house, I was with other PTs and one person that wasn't a PT. And I specifically remember she would have people over and we would be like, well, we can't like stay up late. We can't get drunk because we got to literally study at like 8 a.m. tomorrow. So we would rip like 3 shots just to try to feel like somewhat normal for like a little while. And then like 11 o'clock would roll around and we'd be like, bed, we're going to bed. That's it.
I mean, I don't hate the routine. It's a solid routine, you
Yeah.
you take the 3 shots, you get a little,
Yeah,
little buzz going, and then
That's not in taking care of babies,
No.
though.
No.
that's in Springfield 101.
Yeah, I can't say that's like a recommended thing to do.
Listen, you had to relax after a long day, and that was just how you did it in
But
college.
PT, it's more recent that it became a doctorate program, right? It was a master's before.
Yeah, it's been a while though. We're getting older. If you don't realize this,
Yeah, sometimes I think about it.
So I've been out it'll be 11 years in May, and I was the 3rd doctorate program class at Springfield. So it's been a while.
Almost 15 years.
Yeah, a lot of programs are still like. Well, I shouldn't say still. I think it's probably a good split. Both of the other PTs we have with us, they did a 4-year undergrad somewhere and then switched and did 3-year doctorate program somewhere else, which probably better work enjoy college balance, but also an extra year of student loans. So however you want to dice it, that's.
Yeah, true. And then you have to do clinicals too, right?
Yeah, and every program's a little different like that. Ours were sprinkled in at Springfield kind of throughout, and then our entire last year was clinicals. We did 3 big ones, like 10-week long ones, and our process for them, this is what's a little weird. Every school's a little bit different. Like I've hosted some students and they just like came to me being like, can I do my clinical with you? There was no like process to like vet me for it. It was kind of like they could find me, and if I said, yes, I'll take a student on, I could. For Springfield, they had location assignments, and we as a class had to like almost apply to where we wanted to go. And then our professors were like, okay, yep, we think you'll be a good fit there. You could go there. You could go there. So I did one in like Connecticut area, like West Hartford. That was kind of subacute rehab. So you usually have to do acute care, a rehab setting, and an outpatient setting. I knew I kind of wanted to go outpatient route, so they were allowing me to do like acute and the rehab kind of together in one.
Or inpatient would be what, like hospital setting?
Yeah, yep, hospital setting. And then that more rehab setting would be more like once people are discharged from hospital, say they have a stroke or something, they might go to like rehab. So usually you have to kind of do separate for those. But subacute settings are kind of far and few in between, and I got to see both. Like it considered like, okay, you got your acute care fill and the rehab fill. So that was my first one. And then second one, I was out in Cincinnati at Cincinnati Sports Med. That was like the one that everyone wanted to go to in our class. So I was super happy. We only sent people on their second or third clinicals and 2 kids for each of those like placements. So that was awesome. That's kind of where all the ACL stuff really started for me. I mean, I was always interested in it because I had knee injuries and stuff in high school, sports injuries growing up, but that I feel like trajectored me into kind of like what I like to see now.
I feel like that's a lot of us in these fields. Either you had an injury, I feel like other PTs we've had on, like Evan talked about that, and you kind of had that experience in high school. Would you have in high school injury-wise? Did you ACL?
Partial. I was a gymnast growing up, so I feel like as a gymnast, I had so many injuries all the time. Like started when I was 5, and then by the time I was in 8th grade, I'll never forget my best friend. We were still our high school varsity team. You could make it as a 7th grader, so we were on that, but solely doing gymnastics. I'd played soccer, other things like younger, but gymnastics was kind of my focus. And it sounds crazy, but even by that age, you pretty much know like if you're thinking your body can hold up to go, like, do I want to continue to do this in college or not? And I was already leaning towards, okay, I'm probably not going to want to do gymnastics in college, even though I'm only in 8th grade right now. So we started playing volleyball, and that kind of became a sport. Like we literally just started it because I remember her being like, we just have to find another sport to play. Like we can't like just do gymnastics. And I'm like, oh, okay, all right, let's go try to play volleyball. We did great. Like made the team that year, got pulled up to varsity early. And
where'd you go to high school? You around here?
No, Whitesboro in like Central New York area, like 350 class size, so smaller, probably like Burnt Hill size.
Yeah.
Yeah.
Not smaller.
Well, it's bigger than we went to Chatham. It was like 100 probably
But
class
not
size.
Shen,
Not-
right?
right.
I deal mostly with Shen, right?
Same
So
here.
we compare it to Shen, and it's like, okay, so it's small compared to that. So yeah, a lot of gymnastics injuries. So I had my first ankle fracture when I was in 2nd grade. Next ankle fracture, 4th grade.
Gymnastics is, we texted about this last night,
Yeah.
and we'll just get in. Gymnastics is one of those crazy sports where you get put into high volume settings like immediately.
Oh yeah.
And think by high volume, I mean a lot of practices during the week, longer practices.
Oh yeah, like 4 hours, 5-6 days a week.
Yeah, and just think about like a pre-puberty kid and their bones and their
So,
tendons and their ligaments.
Yeah. No one's keeping track of like any of that either. Like the amount of like jumps you do, the amount of like that's just not tracked. There's one guy I went to college with. He works at Champion PT
Yeah,
out in
Dave,
Boston.
right?
Yeah.
Tilly's great, man.
Yeah. And sometimes I will even reach out to him if I have a gymnast person that I'm kind of like, okay, I'm worried about this turning into blah, blah, blah. Let me share an MRI with you, that kind of thing. But yeah, and I feel like he's probably one of the only PTs I know that is so ingrained in that area that he does control a lot of that on his aspect. But the gymnasts I see, it's just, oh God. You guys have.
We have
one.
some.
You do,
We
right?
have-
Okay, I'm like, I feel like we have a shared
couple.
one.
Yeah, we do.
Yeah.
Is it hard because the pinnacle of that sport, your peak happens at 16 years old?
Well, it's honestly, puberty is where things go way downhill for
Right.
gymnasts. So I think it's almost like a race to get as far as you can before you hit puberty.
Like, Paul, what's the average age of an Olympic gymnast? You're in your teens.
Because they have to be a certain. You have to be a certain age to compete in the Olympics.
16. I think it's changed to 16. I'm
feel
pretty
like-
sure. It was 14 though, because I remember
I think it's
1996
17.
Olympics. Is it now?
It might be.
1996 Olympics. Dominique Mucciano. She was 14.
Yeah, like
Yeah.
when we were growing up, it was probably like
That
14 to 16.
look it up. Let's see.
Age.
But yeah, so what's the? I mean, to improve at your sport, if everybody's working at this pace, you kind of have to, right? Or no?
To like go as hard as they do.
Yeah.
Gymnasts. I think where it falls apart with them, and I kid you not, there's one gym I'm treating more than half a dozen of them right now.
Well, and there's an issue there because if you can't practice, then you can't get better because you're hurt. So it's like, yeah, the answer isn't just throwing them into more volume. Go.
So one thing quick, because there's an article on NBC.com, sports.com that actually talks about this from the 20, what would have been the 2020 Olympics.
Yeah, it got pushed to 2021. Yep.
It was the first time that more non-teens than teens competed.
Yeah, and that's and actually this is like something I'm sure we'll talk more about too, but this is where like the knowledge of strength training and proper training and nutrition and all of those things have come into play so much, because now people's bodies, if they're doing things correctly, can hold up better, right? Back when I was a gymnast, like no one did gymnastics past college. Like that was it. If you were 22 in the Olympics, you were like old. That was old.
So 1968 Mexico Games, the median age was 20 years, 1 month. It dropped to 18 years, 2 months in 72. Then from 76 through 2000, it was somewhere between 16 and 17. Then it was in the 18s from 04 to 08, and the 19s from 2012 to 2016. So it's slowly becoming more actual adults or like non-teens competing, which I think probably has to do with rule changes and stuff like that too, I would assume, as far as the Olympics go.
Which is good. Are there limits? No, there can't be, because nothing's like regulated like a federation. Like if you were at a gym around here, you could practice as much as you want.
Yeah, not to my knowledge, there's not. And summer sessions, you guys would die. They do like 2 days a week. They literally are there for 8 hours. There's 4 events in gymnastics. And I'm thinking, why would you ever possibly need to practice for 8 hours a day, right? So it's just too much load. And then they try to sprinkle in conditioning, which is great, right? That's being included, but just the like how it's taught isn't wonderful. So that's why then you are starting to get some gymnasts here being like, okay, this is how you need to strength train.
So I'm trying to think of a similar sport. I mean, swimming isn't as much volume, but it's kind of similar, I feel like, where you're forced into a lot of hours early on. But you're in a pool, you're not against gravity, your body's not going through like as high intensity of movements. But yeah, so if you want to balance like the volume you're doing in gymnastics, strength training, what nutrition you said?
Yeah, nutrition. And then, I mean, plyometrics are huge too, right? Like you guys know more than any of us, like proper protocols on like how much you should be doing that. And that's not tracked at all in gymnastics. So just the amount of like load, landing, that kind of thing.
Well, I think with plyometrics too, people miss the boat because they think plyometrics is just like this really aggressive jumping protocols, right? But it's like if you don't have enough just like baseline strength, eccentric strength, be able to control landing positions, like you have no right going through these high volume
and the
crazy plyometrics.
Landing positions we're going to teach in here are probably going to be a little different than they teach in gymnastics, because with some of the gymnasts that we get in here, like or my niece, for instance, who did gymnastics for years, when she would come in, I would have to coach her into like being more in like that athletic,
like getting a hip hinge,
position.
getting a hip hinge,
They
right?
would want to land like straight up.
Yep,
And
exactly.
it's like that's not great for your joints.
No.
And like
No.
especially on a hard surface like ours, like so a lot of those things you got to kind of coach out of them. It's just like anything that we do in here. When we have a baseball player, a lacrosse player that goes into extension, is coaching out of extension all the time because they're always in that.
Yeah, and I
that
think people look at gymnasts thinking like, oh my God, they're all so strong. And I could tell you as a former gymnast, the amount of injuries that I had, and yeah, I wound up in PT and things like that, and that's how I ended up becoming a PT. But looking back now, I'm like, oh my God, if I had a PT who like thought the way that I treat kind of thing, I'm like, I feel like it would have made me a better athlete. And just changed how I moved a little bit more, because none of that was really, that really wasn't the thought process back then.
No, none of this was a thing. Not PTs that understand sports, not private strength and conditioning facilities like we have. But yeah, I think they're strong. But think about like Paul, they're strong in like one position or certain
Mhm.
Strong in
positions.
certain positions, and then might not be in others. But then they're also, and they're very flexible or mobile in certain positions. But then other positions, you're like, wow, you can't get your hands over your head,
Yeah.
like
Yeah.
because you're doing so many pulling things out a bar.
Yeah,
or
like
whatever.
you're like, oh, you don't even have overhead shoulder mobility, and
Yeah.
yet look at how many times you're flinging your body like backwards.
Yeah, I mean, think if you're just so strong in this like extended pattern, so like your back extensors get tight, your lats get tight,
Mhm.
but then you have with a young kid whose bones aren't fully developed, like you may be really strong in those positions, but then your facet joints are getting worn down too.
Totally
you-
spondies.
spondies.
Definitely see spondies.
Mhm.
And then hip stuff because they're forcing so much hip extension that it's just like you're just cranking on that car. Like I didn't properly learn how to stretch a hip flexor until I think I probably was a PT. And I'm thinking my whole life as a gymnast, I was stretching my hip flexor like this when I was just cranking my hip into so much extension, being like, oh, let me see if I can feel a stretch. I'm like, oh, there goes my joint capsule.
Yep.
Yeah, you're saying you're just like pushing into like excessive hip
Yeah.
extension and lumbar extension,
Yeah,
probably.
we see
totally.
that in here all the time.
Mhm.
And
Yeah.
I'm like, wait, stop that.
Yeah, let's fix that. So that's why when I have the gymnast come in, I'm always like, okay, it's not that I disagree with what you're doing. It's just how it's being carried out is like so insanely wrong.
Yeah.
And then because of me having my gymnastics background, that's where it gets really fun. Actually, yesterday, because it's a quiet week, everyone's on vacation. 2 of my gymnasts came in. No one was in there for like 90 minutes after them. So we have an air track in there. Like we busted out and actually like worked on a ton of skills. And that was great because I feel like my PT brain can kind of put some stuff together that maybe like cueing wise isn't happening with our coaches. So that always makes it fun.
What's getting hard for us in here is I feel like it's rare you have a kid that has a true off season now.
Yeah.
Do you feel like that too? Like kids are doing their sport all year round. So it's harder for me programming and probably you too, Paul, to be able to see maybe a 3-month block where I can work on a sprint progression, a plyometric progression, because if somebody's doing basketball 4 times a week, I'm not going to jump you and sprint you in here.
Yeah, because you're going to overload them.
They're doing it so much already.
Yeah.
So it's like now we miss opportunities to either build speed, either work on their landing positions and work on deceleration, because it's like I can't jump you more because you're doing it so much outside of here. Or same with
Yeah.
baseball and med ball throws. Like I don't program them at the volumes I used to.
Yeah, or people then will say like, okay, well, I'll play another sport, but then they just keep playing all those. I have a girl, love her. She's awesome, but she plays 3 sports, and like maybe one of them she truly plays in season, and otherwise is playing all of them. And like she'll come in with like knee pain, and I'm like,
Like
oh, what are you doing this
all of
weekend?
them
She's like,
at
I'm
the same
playing.
time?
Yeah, yeah.
Oh.
And she'll be like, oh, I have basketball for 4 hours, and I have lacrosse for 2, and I'm thinking like, all right. And then you almost feel kind of stuck because you're like, where am I? How am I gonna fit into this equation? Because
Yeah,
like, you know, we
because-
gotta take a break.
Because workload management is such a big thing.
Yeah.
So in terms of if you're a parent listening or a coach, it's just the amount of work a kid's doing throughout the course of a day, week, month, year, what they're accumulating. And everything counts. It's not like, well, I just did baseball 4 times this week. It's, well, you did baseball 4 times. It was this many swings, and you had 2 basketball practices, and you lifted 3 times, and you lifted in school. It's like, that's a lot for a young kid's body. And you have to just like understand that and appreciate it. Because, yeah, I feel weird sometimes here because a kid will come in and that's their week. And I go, what the hell are you doing here? You know?
You're like, I mean, I
Go-
want to see you, but also like,
Go home, take a nap. Like,
Yeah.
what are you doing? Here, I got a pillow for you. Come over here.
Yeah.
Yeah. I think
Let's
you're
just
going to.
meditate today.
Yeah, I think you're going to see our field shift to where we're just like kind of managers. Like let's just help you recover enough. Let's build baseline strength measures. Let's make sure you're staying healthy,
Mhm.
and less just like,
Well, and I've had that conversation probably multiple times this week with kids with the stuff about like school lifting, like lifting for gym class
do
or
you see
whatever.
injuries from kids lifting in school?
Yes.
Okay, we do too.
Yeah, a lot.
And basically, and I think that's us as coaches is we also have to educate them as much as it may not, they may be in 8th grade and we may not think that they'll retain it or whatever, but the more you continue to like hammer it home, eventually it's going to pick up if they don't pick it up right away, where I'll explain to them like, yeah, I know you like to squat and deadlift and bench, but you're doing that in school. So we're not going to do that here
Yeah.
because we're not going to double dip.
But it's
right?
hard because then now we're missing key opportunities to teach them
Or
how to properly move under
Yeah, I was
load.
gonna say it would be way better if they were doing that
Right.
here
So
with
then
you
I'll
guys.
tell them we'll do like if they're in, let's say it's a 3-day program. I literally just had this conversation with a kid yesterday. I was like, if you're on a 3-day program and you're in your heavier lifting section of school, because right now I guess they don't do any like compound lifts for like the rest of the year. But the beginning of the year they do. I was like, we can still like bench in here or floor press or whatever, but like we'll pick either squat or deadlift for 1 month, and then we'll switch it the next month. And that way you're getting coaching cues in here, but we'll keep it lighter in here because I know you're not going to do it there.
Yeah.
But like that way that they can get some coaching cues in here that they can hopefully translate to when they're
Yeah, and
at school.
I mean, you guys try to like break into that a little bit and see if you could be like roll in, teach basics, because it all comes down to like the foundational movement is just, it's not there. Like the amount of kids that will come to PT and they're telling me what they're deadlifting in school. And I'm like, let me just see like a hip hinge. And they have no clue how to do that.
Yeah, well, I think, a strength number is a strength number. So the weight you lift on the bar, you lifted it, and that's what you move. But how you move it is what really matters.
Yeah.
I'd rather have a clean 185-pound deadlift than a crappy 300-pound deadlift.
Yeah, I mean, I use the analogy with baseball kids all the time. Baseball's super easy to use this with. I'm like, if you could throw 100 but you can't throw a strike, does it matter?
Yeah, that's a really good analogy.
And they're like, no. And I was like, so I don't give a shit if you can lift 400 pounds if you can't do it right.
Yeah,
like
that's
I don't
an
care
awesome one.
how much you can lift if you can't do it right. I'm like, if you can hit the ball 110 miles an hour, but you can never hit a pitch unless it's on a tee. Does it really matter? Like, no. So let's do it right. And like some kids it registers with, and
I know I'm going to
not.
start to use that one. That's a good one.
But say I like the idea that kids are lifting in school because it gives kids that may not be able to afford a place like this or have gym access at home a chance to get in the weight room and lift, because it's an awesome opportunity to get yourself better at your sport and build confidence.
That's what I like it more for.
That's what I love it for. But what would you as a PT who wants to keep people healthy but keep them performing well, like what would you say if you had a chance to talk to people that are running school lifting programs? Like, hey, let's consider these things first, and then you can build your program on these things.
Yeah, so I think honestly, just going through a basic movement screen. Actually, I saw an Instagram post from one of the many PT accounts I follow, and it was just showing, it was a group of like 12-year-old kids, maybe 14-year-old kids, just goblet squatting a 45-pound dumbbell. All of them picture perfect, right, form. And it was basically like, if you can't do this, you should not be squatting with a bar, right? And that makes so much sense because you're like, oh yeah, perfect. Like good ankle dorsiflexion, like ability to control the trunk position, good hips, all that stuff. And that's just not looked at. So and I don't know, maybe they don't have the personnel to like do that kind of screening, but it's almost like everyone should almost be screened in a way. Like come in, screen their movement patterns, run them through an SFMA based kind of thing.
And I think even in a simple measure, have a simple set of exercises, kettlebell deadlift, goblet squat, body weight push up. And like, you don't need to know biomechanics perfectly. And you can just be like, if this looks like crap, it's probably crap.
Right.
Use an eye test. And if it looks good, you have the right to progress. But if not, we got to stay here until it looks good.
Yeah.
It's a simple way to use. We could have 30 kids in here, 40, and we can do all, if we had enough equipment, goblet squat them, and 2 of us can go down the line. Good, not good, not good, progress, you stay here.
So that's where you bust in a shin and be like, let's fix this. Because like you said, it's a great opportunity though, and gives some kids some more accessibility to like having the opportunity to do that. But and then though, it's kind of the flip side of it. Like if you think back to gym class, right, when we were growing up, like, do you think it's taking away from them a little bit that they don't just get to play in gym?
That's where I'm at.
That too, Sam, because gym class was fun. We played floor hockey and we played ping pong. I loved ping pong.
Yeah.
You were just doing gym class.
The softball unit was questionable, but I loved it. I loved every moment of it.
That's a good point, though. I mean, I guess maybe you have the option for kids in terms of what they want to do.
And they do it. Like the one kid I was talking about that does like the school lifting, I told him, I was like, dude, I might tell your mom, like, just to put you in regular gym, like, just go have fun, go play.
Yeah,
like,
what's wrong with that?
Like, go play some basketball, go like have fun. But I also, maybe, I don't know, friends aren't in the class. It's different. I don't know. I went to a very small school, so a lot of my friends were in gym class with me.
Yeah,
like, so
true.
And
so I guess you get a scenario like Shed where all the athletes are in. Right, they're all in lifting.
Yeah.
So
I mean,
people be like, no, I don't want to go back to gym class. None of my friends are there.
I just think there needs to be a better way to structure things.
I
That's
just
all.
think the simplest thing would be require whoever the gym teacher is, the phys ed teacher is, to be certified.
Yeah.
Simple.
Like,
And I don't know.
that's a simple fix.
I don't know if they are or not, so I don't want to. I don't want to
I don't
speak
know if
to
they
it.
are or not, but my guess is probably not.
We write notes all the time to get kids out of gym and don't have any issues usually doing that. And I'll even put in there like, okay to do their PT stuff though, because I'm like, well, I want you to sit there, like do some stuff, but just don't do that.
I think yeah, it's understanding what quality movement is and what loading things appropriately is and workload management with kids. And then also it's like, what are your priorities? Because in some gym classes, 1 rep max is the priority. There's a leaderboard. Kids have egos. They
Always.
They
hear
want to
about
be
it all
on,
the time.
I was on the leaderboard.
Uh-huh.
I'm like, I don't care.
I told the kid yesterday, I was like, 5 years from now, that leaderboard's not going to mean a damn thing. I'm like, you know what's going to mean something? The fact that you stayed healthy enough to be able to play a college sport.
Yeah. So I think it's that. You just can't, especially with high school kids, you can't make the 1RM a priority. Kids are going to listen to us. If we told them in here 1RM's a priority, it's a priority for them. They have trust in us, so we have to do what's right for them and put them in a spot where they can stay healthy.
There's one of the teams, they have a 1 rep max test next week before they have tryouts. The week before they have tryouts.
On everything? Like every main lift?
Squat, bench, clean.
Jeez, it's like let's minus 2 kids off of that team right away that
Yeah.
may get hurt.
I was talking to one of the girls in here, and I was like, all right, this is what I think you should be aiming for squat. I don't care if you can do more. Bench, push it. Don't care. Go ahead. Go for it. And then cleans, I was like, just be smart. And
I think, too, something with their gym, it's like they just have to beat what they did previously. I feel like
Yeah.
I've been told this before, so you
You
theoretically
mean like
could
it's like recommended?
to pass the gym class. It's something like
That's
that. Like in order
wild.
to pass, and maybe I have this totally wrong, but I've been told this by multiple people. They're like, yeah, so you could just like do less, and then like if you just beat it, you just like the end of the semester, you just have to like beat the weight that you did in the first.
Yeah, this is for like their team, not for the class. But like,
Right.
yeah, I
Oh.
think that you are right in something
Yeah.
like that, like or it's something weird,
Yeah.
with, like the numbers and whatnot. But this was for a team, and like it's back squat, and we don't back squat in here for a reason for her because it's not the best position for her.
Yeah.
But I was like, you're gonna have to do it. So let's put a number that we think is realistic, that you're not gonna hurt yourself. And
Yeah,
she
because-
was like, yeah, all right, sounds good. I'll do that.
See, that used to be the case with college kids. Like, they're to a college program and they're going to back squat and they're going to like hang clean. So we'll do it in here to make sure you're doing it right.
Yeah.
But usually that's the only scenario. We'd be like, okay, we're going to work on loading those things.
Mhm.
The supplement industry is like the Wild West. The lack of regulations mean the supplements you purchase may not even contain the ingredients listed on the label, which is why I get my daily vitamins and supplements from Thorne. Thorne vitamins and supplements are made without compromise. Quality ingredients ensure your body optimally absorbs and digests your daily supplements, while in-house and third-party testing ensure you're getting exactly what you paid for. Thorne offers a variety of health tests reviewed by board-certified physicians that evaluate your lifestyle, gut health, sleep, stress hormones, and metabolic markers to determine which vitamins and supplements may be most effective in helping you feel and perform better throughout the day. For college and professional athletes, Thorne has NSF-certified supplements that make sure you won't get pop positive on a drug test. Whether you're an athlete, professional, parent, grandparent, or weekend warrior, Thorne's selection of high-quality supplements can help improve your quality of life. Switch to Thorne's high-quality and extensively tested supplements today at thorne.com/u/CDSF. That's thorne.com/u/CDSF. This episode of Off Exit 10 is brought to you by Anchor and the all-new Anchor Pro, crafted to endure the most high-performance workouts without the high cost and space requirements of a standard cable machine. Named the best portable cable machine by Men's Health Home Gym Awards, Anchor provides the full functionality of a cable machine in one small space-saving unit. Designed with user-friendliness in mind, Anchor can simply be attached to any squat rack or placed on any wall in your home gym using its intuitive sliding track mount. With up to 65 pounds of resistance, Anchor is built for high speed and controlled exercises alike, from cable presses and rows to chops and lifts. The Anchor has been a game changer for us here at CDSF, and now you can enjoy the same professional quality cable machine in your own home gym by heading over to anchortraining.com and using code CDSF10 for 10% off your order today. Get all the benefits of a cable machine without the high cost and installation fees. Enjoy the portable luxury and space-saving performance of Anchor today by going to anchortraining.com and using code CDSF10 at checkout. That's anchortraining.com, promo code CDSF10 for 10% off your order today. You see more ACLs now, or it's kind of been steady from the time you started?
More now, but also some of that just comes from our growth, right? I've switched up. I worked for a year in our Latham office and then switched to Clifton Park, and it was me and another like 20-hour-a-week PT. And now we're like staffed usually four full times, kind of ebbs and flows. Sometimes it'll be like 3.5, but so I think we see way more, but I'm also like, we just see
More people.
Right, more people. So it's hard to say specifically, but I think too, you're with an ACL for so long when you're with them that like that kind of starts the chain of like, oh, my friend tore their ACL and like now they're going to come to you. So I think a little bit of it is a snowball effect too.
Mm-hmm. What grafts do you see the most of now? What do you like the best?
That's a good question.
If any.
Yeah, totally. So when I was in Cincinnati Sports Med, so like I said, there where I was, one of the like long-term ACL guys, he's much older now, surgeons, but who wrote like all the textbooks, did all the studies on ACLs. His name is Dr. Frank Noyes. He was always big. So this was 2013-ish, 2012. Very big on patellar tendon. And that's when hamstring grafts were like really growing in popularity though. But out there, I was pretty much used to patellar tendon grafts. And then you fast forward me to like starting in a clinic working here. And a lot of the grafts I was seeing was hamstring. And I'm like, well, this is crazy because I have the knowledge I have from there and just kind of like, and not that, and a lot of people do still get a hamstring graft, but basically like long story short of it is hamstring graft is a little bit structurally weaker than a patellar tendon graft, which most people would be like, oh, big deal. But the re-tear rate ranges from anywhere to 10 to 30%, and younger athletes, it's more like 20 to 30% in the first 2 to 5 years returning to a sport. So that's like insanely high, right? So I'm thinking, why would you choose the graft that's like slightly gonna increase that failure rate? But so anyway, that years ago, it was a lot of hamstrings. And now I've kind of seen a turnaround probably in the last 3, 4, 5 years. I would actually say we have more patellar tendon grafts than hamstring grafts. There's one doctor specifically in Ortho New York. We end up with a lot of his, it's kind of a Shen connection. Trainer at Shen knows him well. So if they don't go to Ortho New York PT and end up coming to us, he's always a hamstring graft guy. But I would say outside of him, it's mostly patellar tendon grafts. Some quad tendon grafts. There's definitely one doctor in bone and joint who he'll do quad tendon grafts. We'll see that more younger athletes too, if they just don't want to cut into patellar tendon because of like growing situations. And then cadaver, like I would actually say cadaver too was being overly utilized when I first started as a PT in that like 30, 40, 50-year-olds because they just used to be like, oh, you're older, just use a cadaver graft. And then they were fouling super high. So if anyone does any sort of like skiing, people still play like rec soccer when they're older, like
Pickleball.
Yeah. You definitely still would not want to go the cadaver graft route. And people thought initially like, okay, it's nice because using the cadaver graft, it just means it's not your own tissue, right? It literally came from a human cadaver. So initial post-op pain is substantially lower, but it actually takes a cadaver graft a longer time to fully mature inside the body. So now you kind of have two problems because people are feeling better way sooner. And we even see it on the PT side. People will be like 8 weeks post-op and I'm thinking like, oh, okay, where are we at? Are we getting, this looks good. Are we getting close to running? And I'm thinking like, whoa, no, you're only 8 weeks post-op. Like we're not even close to that. So and they feel that good, right? So they start to be like, I'm feeling good. I can do it.
Because minimally, regardless of the graft you use a tendon graft. You want it to act as a ligament. Over time, it's going to change and structurally start to act like a ligament, but it's going to take what minimally until you feel like it's kind of fully mature.
12 to 18 months for like that ACL graft to fully mature. And I will tell my first visit with every injury, but especially ACLs, I feel like I could do the evaluation part in like 10 minutes, but I'm like, listen, we're talking for a good 75, 90 minutes here about going through like, you need to understand the surgery because doctors don't really spend that, right? How much time does a doctor spend going through that? They don't even, most of the times they don't even, I'll ask the patient, like, how'd you get this graft? And they'll be like, oh, the doctor just gave it to me, right? Very rarely is a patient like, oh, I told the doctor I wanted to do that graft.
Right. Okay. So let's just say you're a high school athlete.
Yeah.
Tear your ACL. You obviously the doctor you go to, you want them to perform whatever surgery they perform the best. Whatever graft that is. But if you had to give advice and say, I think in the long run, you'll be better off if you had this, you would say
patellar tendon graft. Yeah, hands down. Quad tendon, though, I should say, quad tendon is just newer in the last few years where I feel like the long-term research isn't totally there yet. This current research coming out is showing it pretty like on par with patellar tendon.
We have somebody in here with the quad tendon.
We had quad tendon, yeah. We have a bunch of patellar tendons.
The one person I'm thinking of is recent, and they're like doing very well.
Oh, yes.
Very well.
Are they younger?
Yeah.
Oh, yeah. They're in high school.
Okay.
Yeah.
And some of that, too, is I think not a lot of doctors in the area do the quad tendon. So that's why I'm like, we have some, but...
We have a few athletes in here who went down to New York City, but what do they do? They use is it the IT band something
Yeah,
laterally, right, to tighten
Yeah.
and create more stability, which I'm
Amazing.
liking. Yeah.
Amazing. Yeah. So it's called a lateral extra-articular tenodesis. So
Well, that's a word.
yeah, yeah. So they
I think
pretty
Jordan and I just had the same look. Like,
so they pretty much found because the rate of re-tear was so high that one of the things that's not restored after an ACL surgery is rotational stability. And that's huge, right? Like you need to have your rotational stability in the knee joint. So they basically take a piece of the IT band, fancy wrap it around just to create more stability for rotation. To me, it's easy because it doesn't change. We actually just had a kid start yesterday who had it done, who also had a meniscus repair. And I was trying to fill my coworker on like what to, look out for it. And it really doesn't change like early course of rehab whatsoever. The person usually is in a little bit more pain, a little more swelling, obviously, because it's another incision cut. The tourniquet time is higher with that, which that's a whole nother thing. But the longer the tourniquet's on, the more swelling and increase in, inflammation you usually have. But once you kind of get past that initial phase, it does not affect your rehab whatsoever.
What about with patellar tendons? We've seen in here at the site where they're taking the graft from, that having like almost becoming more of a pain issue down the line than the actual ACL reconstruction.
Yeah. I'm going to blame rehab on that one.
No, go, 'cause we've seen it before,
okay.
yeah.
So, I mean, they're taking a chunk out of the middle of your patellar tendon. So I would say it's one of two issues, either too much load too early on, right? Like too much quad load. And then you basically develop patellar tendonitis because you're just...
They're taking that same side or contralateral side?
Same side. So they cut right into it. You can literally feel it. Like I'll have my patients who are like 4 months out. And at this phase, we're running, we're jumping, we're doing a lot of single leg quad work. And they're not having pain, but you can actually feel the like divot kind of like filling in almost because they're cutting out the central like 1/3 of the patellar tendon to do it. So, I think it's mismanagement of that. And then you have to work on the biggest complaint, like after a patellar tendon graft, is like inability to kneel on the knee.
Yes, we see that all the time.
I can be honest and say I don't think I've ever finished up with an ACL who had a patellar tendon graft that couldn't kneel. Like we just like make it, like I tell them, I'm like, it's not like one day you're just going to wake up and be able to kneel. So you got to start doing it
I feel like
early.
that's like a hypersensitivity thing. They just have to kind of gradually introduce themselves to kneeling and putting pressure down into the ground.
Totally. And I tell them, I'm like, it's going to feel weird at first because you're numb, but it's way better to be kind of numb when you start doing that versus like having your sensation all screwed up as you're nervous, grow back into place.
Yeah. If you had to give a minimal timeline to, and everybody's so different and how they progress through the rehab is different and how they move, of this is when you're going to return to the field, like what's your minimum? It is no earlier than this for a high school kid.
Absolutely no earlier than 9 months.
Yeah.
But more and more research is coming out on this being like, again, ACL tears are so common. I read so many, that's probably like the thing I look at journal articles on a weekly basis of, and so many more studies come out just kind of saying, even in professional athletes who have literally like PT, strength and conditioning every single day of the week at 9 months, there's still differences in how they move compared to someone who has not torn their ACL. Like not just quantitative data, but qualitative data. And it's like, okay, if they still, as a professional athlete, cannot be moving correctly at 9 months, like, should our high school athletes really be doing this? So it is hard though, because as a PT, I'm usually going against the doctor on this one because most doctors in this area are still stuck on the 6-month train. And then I have to be like, I bust out articles though. I try to blame, I'm like, here, look at this. Don't blame me. And, I'll pull out articles. But I mean, there was one article printed a couple of years ago and I have it sitting on my desk because it's usually my high school males specifically that I have to be like, just look at the title of this. And it's basically like for every month prior that you return to sport prior to the 9-month mark, your odds of re-tearing increase 7-fold. Like 7-fold.
Yeah, it's like, think
That's
about
crazy.
that. Do you want to feel this way again and go through this again? It's like not a chance.
And you put so much time and effort into that rehab phase to, and I've had, again, I would love to sit here and be like, I've never had an ACL re-tear, but I've definitely had ACLs re-tear. And I can tell you what eats at you more is when you are telling the person like, okay, I understand you're passing all return sport testing. You're doing great, yada, 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 but you're only at this time frame. And they choose to listen to the doctor or listen to the coach and kind of say, well, it's not going to happen to me. And then it does. We don't see it a lot, but in my 11 years of practice, have I had then someone, and a re-tear, this is interesting too to know, a re-tear in our world is considered tearing the same side again or the opposite side. Statistically speaking, they just roll it all into one.
That's interesting. I like that you use the the pro athlete thing, because anytime we have somebody with ACL stuff and they say the 6-month thing, and I was like, no pro athlete comes back after 6 months. I'm like, the fastest I remember somebody coming back in the time that I like of a pro athlete was Adrian Peterson. I think he came back in like 8 or 9 months, but the first 3 or 4 weeks of the season, he was good, and then the last 12 weeks of the season, he was the MVP.
Yeah.
Like, that was the difference. Like, he was the best player in football for the last 12 weeks because he had another 4 weeks. Now, he's also a freak of nature, absolute freak of nature, and has the best possible care that he could get probably 20,
I mean, he was probably in
24
the
hours a
rehab
day.
room like 4 hours a day, right? I use the example of like Lindsey Vonn, for example, like skier. I'm like, look, I think that chick tore her ACL like 4 times, right? I'm like, you don't think she wasn't getting like the best of the best of the best rehab? But it's like the ACL, it just takes so long to remodel itself. And then we know you're not restoring like normal tissue level. Yeah. And I try really hard to like spit out stats at patients. Even if they're not going to remember them, I just want them to be like, okay, this isn't just some lady telling us her opinion. Like, this is what the research says. And it's literally less than half of people return to the same level of competitive play that they were at pre-injury. Or I think it might be 55%. It hovers right around half. So it's like, think about that. Like, meaning you might go back to your sport, but are you as good as you were before?
You're
it's like
saying
50% chance.
If you go before 9 months or before, or just in general?
Just in general.
that
Who
shows-
makes it back?
Yeah. That shows how serious you have to take after you do your initial, let's say 6, 7 months of PT, how serious you have to take those next 5 plus in terms of, what are like protocol you're looking at or quantitative things or just exercises you want to see done well at like that 7-month mark to say, okay, now like we can start to do in a controlled environment, maybe some more speed stuff, maybe some change of direction stuff, maybe stuff that looks a little bit more like your sport.
Yeah, we usually start our return to sport testing. I'll start putting them through portions of it around the 4-month mark, definitely 5-month mark. One of that doctor I talked about, and I don't know, do we drop doctors' names on this?
No, we won't drop a doctor's name.
So one of the doctors in North New York who will clear people at 6 months, he has a pretty rigorous return to sport test. Some of it, there's like a 10 rep max on there. Like, that's interesting, right?
Yeah.
So yeah. Anyway, so we'll put them through that a little bit early because we also don't want them to just like go for this appointment at their 6-month test and want all the results and not go through it. So we always do, we will do 1 rep max testing for like leg extension for quad strength because that's by far like the thing that lags behind in rehab. I can't tell you the amount of times I have someone switch to our PT clinic who might have been somewhere else. They're 6 months post-op and they're like, I don't know, I'm going pretty well. It's going pretty well, but I can't run without pain. I can't jump. And like, I'm like, all right, let's just see where your strength's at. I just had a girl recently, 6 months post-op. She showed me her squat. Squat looked pretty good. Single leg squat. Didn't look bad. Huge hip hinge though. I'm like, all right, let's just go see like where you're at right side versus left side. She couldn't even leg extension 10 pounds on her ACL side, and she was at 160 on the non-side at 6 months
it's like
post-op.
then when you're squatting, you're compensating, obviously.
And even on the leg press, she'd be like, I always feel it in my glutes. And I'm like, well, yeah, because your quad's not doing anything.
Yeah. Well, okay, like priority early on, we just talk about all these bigger movements, but you want to see what? Get back the knee hyperextension and get
knee
the quad.
extension. Everyone stresses about knee flexion, but I'm like, as long as you work on flexion, like it will come. You know what I mean? I don't really ever have issues with knee flexion coming, unless I will say the one caveat is if someone went into the surgery with horrible range of motion and a lot of swelling, we do see some setbacks from there. And I think delayed ACL surgery is kind of a growing trend too. Like, doctors don't just necessarily rush into doing it right away.
But that's a clinical choice based on assessing somebody and saying like swelling or your range of motion isn't great. Like, let's try to get this back a little bit before we go do surgery.
Totally, yeah. And I would love to see everyone pre-op, but we don't always see them. But sometimes it's nice just to give them a rundown of like, okay, these are expectations. So yeah, right off the rip, it's definitely getting extension back, getting swelling down, and getting quad active, and then starting to do quad stuff right away. And that's where, like, again, research, like we need to be doing. When I first started out as a PT, we were at least where I was trained with Cincinnati Sports Med, we were always doing open chain leg extensions because it's the only thing that isolates your quad, right? It's not fancy. It does, you know what I mean? It's not fun to do.
Open chain, if people don't know, would mean you're not planted in the floor.
Correct. So literally, if you would envision sitting in a chair and just kicking your leg up, right? Like your thigh stays still, but you're kicking your leg up. That's open chain leg extension.
Closed chain would be
like putting your foot on a leg press and pushing a leg press, or squatting, right? Your foot's on the ground. But then other muscles come into play. So a seated leg extension is the only muscle that is doing that is your quad. So for a long time, there was all this talk about, oh, there's too much strain on the ACL, so we can't do open chain, leg extensions. And now they've done better studies to say, okay, there's actually more strain on the ACL graft when you walk than when you do a leg extension with a 10-pound weight wrapped around your ankle. And it's like, you're cleared to walk right after an ACL surgery. So do I strap a 10-pound ankle weight to people and have them do, a seated leg extension right off the rip? Absolutely not. But it was kind of one of those things that no one was doing open chain leg extension for years. And then all these people were re-tearing their ACL, and they started to realize like, oh, quad strength is a huge, huge problem here. So we try to get after that and make sure the person knows. And then it's what works with these athletes, you guys know too, like you give them objective data, like, okay, we will not start running until you are at 75% operative side versus non-operative side on leg extension. We have other criteria too, like amount of single leg calf raises, amount of single leg squats, but that's like one strict one. Like, I will not budge on that. I don't care if you're 5 months post-op. If you're not there, we're not running.
Paul, was that helpful for you coming back from your Achilles to have these objective measures as like an athlete to say, hey?
Oh yeah. I mean, having things that I had to do, just listening to all of this too makes me go, as shitty as your Achilles is doing, I'm so glad it was my Achilles and not my knee.
See, I actually disagree. I think Achilles rehab is worse.
After watching Paul go through it, I'll be like, walking around the house, and I'll be like, oh, my Achilles is kind of sore. And I'm just like, oh, shit, I can't have this happen.
The rehab itself might be worse, but I feel like post-rehab, and maybe it's just because I put in the work, but I also feel like I don't hear about a lot of people re-tearing their Achilles.
That's okay. I'll give you that one. That's fair.
Whereas,
yeah.
And this is what I was gonna say this before too, was like growing up, in the late 90s, early 2000s, watching football, like the amount of guys that would tear their ACL and immediately you're like, career's over. Their career's done. They're never come playing again.
Yeah, well, that's prior to all the sports med and the PT and the training that we have now.
At the same time, like going back to what we're talking about with kids wanting to get back on the field or doctors getting them back on the field too soon, is like, this used to be an injury that was career ending.
Right.
The Achilles used to be career ending too. It's not anymore.
Yeah.
But like, it used to be a career ending injury, and it still can be, like you said, 55% of people, right? But kids don't view it that way. And if you did, then maybe they would take it a little more serious on okay, I don't need to rush back. I don't need to get back at 6 months. Like, this could be the determining factor of, I'm going to get to play lacrosse or field hockey or football or whatever for the next 10 years or never play again. And like, I think sometimes that's not in the front of their mind. They're just like, I got to get back in the field. I got to get back in the field.
Oh, we literally had that kid yesterday and I was talking to the dad because his brother was a former patient of mine, and I was like, well, at least he doesn't have to, it's a football player. I was like, at least he doesn't have to worry about football next year. And the dad's like, oh, well, yeah, he thinks like he's going to be good. And I'm thinking, okay. And my coworker was doing the eval, so I didn't step in on it, but I'm like, he's going to need some education, right? I'm like, that's not, I actually went home and like did the math. I'm like, he wouldn't be 9 months until the end of November. Like what's, no, let's wash it. So yeah, so with our return to sport testing, we just look at a lot of stuff, strength, plyometrics. There's a whole bunch of, it's like a huge battery of tests. So a bunch of hop testing we'll do. I always do a single leg squat endurance testing. I think endurance is an area kind of underlooked. We've talked about this a little bit before
when it comes like endurance tests.
Yeah, well, because fatigue, right? Fatigue plays a role. And sometimes like initial strength looks good and then you kind of see it fall apart and you're like, oh, that's not good. Vertical jump testing has been like more common coming up in the literature too. So we're incorporating some of that. And I tell people, even at 6 months, like I'm just looking for you to be at a certain range. And I'll be honest, if someone is, so passing is technically considered over 90%. For me, I want like 95% or above because a 10% difference is still pretty drastic. There was a study done that I think the cutoff was under 90%, but for every 1% difference in quad strength, it was a 3% increase in the risk of re-tearing. So if you were, a 5% difference, it's like, oh, well, actually, let's amplify that a little bit, So yeah, I think just telling them expectations where they should be. So if someone's passing really early, then my brain goes to, are you really passing, or has your other side just gone to absolute crap during this process too? And
because they're even.
Yeah, because if someone's not loading, like hopefully this is standard across the world, like across the board with rehab. But when we've talked about single leg, my love for single leg exercises, but we don't just do the operative side. You're doing everything on the non-operative side. And again, like I said, stats and like stuff from research is like my my thing. But they actually looked at a study where kids like did their testing at 6 months and like a percentage of them passed. They looked at they put them through all that testing before surgery on their good side, though, right? So you got their good side like around the time frame of injury, and then you're doing the 6-month post-op testing on both sides, right? And if they compared the 6-month post-op side to side, you know, it's like, oh, great, 90%, like you're passing. But when they took the numbers from pre-surgery and used that for the non-operative side versus the operative side at 6 months, you get me?
Yes.
A little bit? Okay. Like less than 60% of them were passing.
I feel like that's what you should be looking at, especially
Yeah.
with return to sport. It's like, yeah, did you
100%.
just let your non-operative side
Get
get
worse.
weak during the
Yeah.
process, and now your other one's just catching up to the side that got weaker?
Yeah.
And that's when we've had people in here, they're like, why do I got to train the other side? I'm like, well, you want to keep that side strong, right? Like
Yeah.
I did so many different stupid single leg variations on my left side of different exercises.
Our calf raise is so fun. Solely
Yeah.
to strengthening.
And there are, you can probably look at research, and there are neurological strength
I was
carryovers
gonna ask
to
if
training the
Sam had
non-injured
any
side,
research.
right?
Yeah.
Which is like a no-brainer idea for like, that's why you should train your other side.
Yeah, I'll even coach that early on with like just simple quad setting. First day, I'm like, you got to do it on both sides because you're going to get some of that neural carryover from side versus side. So your non-operative side will kind of like, in a way, teach your operative side, like, okay, this is how you do this. But, and then we do a lot of double leg movements and stuff, but we've always talked about like single leg. It's like, you can't hide as much on a single leg as you can on double.
No. And that's the better carryover to sport. It's a safer exercise in the gym. It's like injuries are going to happen. I used to be, when I first started like in this field, like, oh, I'm going to prevent all the injuries.
Can't prevent injuries.
Can't
That's how I
prevent
used to be. I used to be
Can't
like,
prevent
none of my ACLs are ever going to re-tear. And I'm like, oh, well, okay.
It's definitely something. I mean, I guess I just had that mentality as a athlete growing up. Like I knew I couldn't prevent injuries. I could just reduce the risk of it. Like, I can't. Injuries are part of sports. It's just the way it is. Like,
So if we're reducing risk of ACLs, like what are your biggest things if you're talking to parents and they go, oh, I'm scared my daughter's going to tear ACL. Her 2 friends just did. Like, what should we be looking for and making sure of to maybe not have this happen to her?
I mean, you guys know benefit of strength, right? Like strength, which it's funny in the ACL rehab side of things, we're always talking about like lack of quad strength. Sometimes though, you guys see this too in your female athletes, primarily overuse of quad, like being super quad dominant, everything being pulled forward. That actually, like the ACL, it prevents that shin bone, your tibia, from shifting forward. What does your quad do? It pulls your tibia forward. So if you're super quad dominant, you're almost like shearing that a little bit to begin with. So actually doing a little bit more hamstring strengthening, learning a little, or at least a little bit better co-contraction. And then it all comes down to like mechanics for landing, cutting, pivoting. I mean, an ACL tear happens so fast. It's within like, I don't know, 25 milliseconds or something crazy of like foot hitting the ground. Your brain takes like 10 times longer than that to react to movement. So there's no way you could ever be like, oh, let me change. I put my foot down wrong. Let me change it. Like, no, you're done. So I think just going back to like the biomechanics of like teaching proper landing, jumping mechanics is huge.
What about time off from sport during the year? You think that's a big piece? Just giving somebody a little break from their body being on the field and playing and practicing, or it depends?
Yeah, I mean, you guys too, probably, right? You'd agree. It doesn't have to be a break, do nothing, but like go do something you enjoy. Go play this random sport. Go on vacation and like swim a little and don't run. Like go, I don't know, go play beach volleyball. Like just move your body differently, because I think those constant stressors just build up on athletes so much.
you don't have to pick up a glove or a stick or a bat or a ball for whatever sport you're playing for it to affect your sport, right? Like you can do something else, boxing or whatever,
to get better at your
to
sport.
get better at your sport.
Yep,
like you
exactly.
don't have to, if you're a lacrosse player, you don't need to pick up a lacrosse stick every time you want to do something to get better at your sport. If you're a baseball player, you don't need to pick up your glove every time you need to do something to get better at your sport. You can do other things.
Yeah, we do.
That'd be
I would
that.
say that comes up with us the most with runners, right? Because runners, all they want to do is run.
Psychopaths.
So you see, I mean, stress fractures.
Stress fractures and just tendinopathies, bad tendinopathies. And I've listened to some great podcasts talking about like tendon healing and all that. And I feel like the important part is like breaking that down and actually like making sure a patient understands like the science behind it a little bit.
Tendinopathies are tough. We have different people with different types of tendinopathies in here at different tendons. But it's a tricky one. Explain what a tendinopathy is, and then I have questions for you. After
Okay,
you do that.
so the old school used to always be like everything's called a tendinitis, which when you take down the root word, itis means inflammation. Okay, we've now learned that when you first have an injury, maybe in those first like 24, 72 hours, there is inflammation present structurally. Like, and we're talking if you take a microscope and like look at the tissue under a microscope, what you see those first couple of days, you'd see some inflammation present. Tendinopathy or tendinosis, kind of same term, is more of the structural change that happens to a tendon. So a tendon is always being exposed to load. There's some breakdown that happens. It should have time to remodel. If there is excessive load, whether it be just too much activity, too much weight, whatever, too much mileage if you're talking about running.
Do you think or not enough load too? Or
I think not enough load is an issue because obviously the tendon gets weaker,
Right.
and then the person, if they go try to that, like this comes up a lot, like, oh, well, I rested and it felt better. I'm like, well, yeah, because you weren't doing you weren't actually applying load,
Right.
so
You're
you
saying
weren't challenging
resting,
it.
but then doing too much load.
Yeah,
post that.
exactly.
Okay.
There's no in between. So with the tendinopathy, if you act, and I will literally bust out pictures for my patients. I'm like, look at, this is what a normal healthy tendon looks like. This is what a tendon that has tendinopathy looks like. And you don't have to be a PT or anyone to understand science to be like, that doesn't look like that. You know, the tendon itself structurally is different. So I always say, think about like a nice smooth road. That's like, right, how it feels. You're driving on it, brand new pavement, great. Okay, you get a couple potholes in the road. Okay, now we kind of fill them in. Like you still feel that when you ride, right? So the tendon itself has just not great tensile strength. So when you contract a muscle, the tendon is almost a continuation of the muscle, so it needs to pull against the bone it's attached to. And if it has all these wavy patterns to it and it's just not as much strength to tolerate, it can't produce as much force as it needs to. So then it's going to break down further. And then if you keep applying that load, it just cannot remodel itself. But if you do nothing, right, like you just said, it's not going to remodel itself either.
So this is where sometimes I struggle maybe in communicating or guiding somebody in their strength program who has a tendinopathy. We'll just use patellar, for example,
Yep.
is that, all right, we're starting to do some exercise. We're doing some partial range of motion things. We're loading that tendon a bit, and they have some pain, and they get frustrated. But you're not going to be perfect when you're loading with a tendinopathy, right?
Yeah, and I actually say, like, I almost want you to feel a little bit of pain. 1, 2, 3 is pretty much my cutoff. And I know pain is very, like, everyone views pain differently. But if it's not changing how you move and you're just like, I mean, I feel it a little bit, that's kind of green light. Keep going. And then more research has come out to also look at like the 24-hour principle, because tendons are finicky, right? Someone could start out, have some pain, and then be like, I feel great. And again, this applies to runners a lot more. They'll have some pain, go out, be like, it went away, let me run further. And then they wake up the next morning and it's like, oh my God, I can't even get out of bed because it hurts so bad. That's definitely like too much load, way too much load. So I always say, pay attention to how you feel now. But if tomorrow you wake up and you're like, it's the same or not worse, then we keep going, kind of thing. And you have to apply that load. But if it's more than that 3 out of 10 pain and you're like, I don't know, it's killing me, or it's staying flared up afterwards, that was too much load. So with tendinopathies, which we see all the time, right? Shoulder tendinopathies are insanely common. Achilles, posterior tib, actually way more common than people realize. I always say we actually know how to like heal them from a rehab perspective, but it's really hard because we're not in your body sensing that load. So I always tell people, I'm like, it's never going to be perfect. We're always probably going to hit a patch where we're like, oh shoot, okay, like maybe we went a little too much, we got to regress, or oh well, okay, maybe we haven't been loading enough, let's go a little bit more.
Right. And then for you as a clinician, like knowing the starting point with that person is what? Like, let's just start less than I think and see how you feel, and we go from there. In terms of loading that tendon, or this is where we start?
We'll start light, but I mean, we follow, like, you try to utilize some strength training protocols. Like, you know, if someone's like trying something, they get through like 10 reps, and they're like, fine, easy. I'm like, okay, not enough load. Like, let's load it a little bit more. So I would definitely say err a little bit more on the side of caution, but I'm also not going to waste time, right? So if we get through like 7, 8 reps clean, barely feeling muscle fire, nothing happening, I'm like, okay, let's go up.
This episode of Off Exit 10 is brought to you by Drink Alchemy. Fatigue and brain fog affect us all, destroying everything we pursue. Whether as an athlete, artist, creator, or entrepreneur, our mind holds the key to performing optimally. By combining the most potent organic nootropics found in nature, Drink Alchemy delivers sustainable boost to creativity, memory, energy, and focus in one epic beverage. Stop pumping your body full of excessive amounts of caffeine and unknown proprietary blends from other energy drinks, and get clean energy from Drink Alchemy's natural nootropics like lion's mane, L-theanine, and caffeine from green tea. Used by Olympians, D1 athletes, MMA fighters, and entrepreneurs, Drink Alchemy has become a huge part of my daily routine, making sure I'm functioning optimally during long days of coaching athletes, running CDSF, and getting in quality workouts myself. So do yourself a favor and ditch the energy drinks loaded with caffeine, other stimulants, and who knows what else, and head over to drinkalchemy.com today. Live with your mind unbound and save 10% off your order by using code CDSF at checkout. That's drinkalchemy.com, promo code CDSF for 10% off your order today. How much do you do manual therapy at your practice?
Our clinic specifically, a lot, I think, and I think it just depends on different types of injuries. Probably I would say at least 90% of my patients get manual at some point. Manual therapy, it's funny how when you start out, what you learn and what you think, and then as you grow as a clinician, you start to learn like, oh, I was doing that, and I thought it was doing that, and it really wasn't doing that, but it seems to work.
You're saying like physiologically?
Yeah. Like, what do I do, right? So we do a good amount of, passive range of motion. I can't think of any shoulder that walks in the door, right? That we're not just checking passive range of motion on, stretching, that kind of thing, unless someone is truly like an unstable overhead athlete. Then it's like, well, I'm not going to stretch you. We're mostly doing mobility work. But even then, other muscles are going to get tight. But a lot of deep tissue work. We use cupping, Graston, that kind of thing, some joint manipulations at times, but it's hard because I always want to take the time to explain to a patient, like, okay, like this is what this is really doing at the tissue level.
Right. Okay. Because we can talk, because I went to massage school when I was in Boston.
Yeah, I knew that. Yeah.
Which was cool. Like I just did it really for two reasons. The first is I was debating if I was going to go to PT school or not.
Okay.
But I knew I only had this small window in time that I was going to live in Boston. And I was like, I don't want to spend this in school. Like, I just want to be able to enjoy my time while I'm here. But then I wanted another tool to be able to help people, to be able to improve my assessment skills, to understand anatomy better. So as exercise science, like I got 1 or 2 anatomy classes, but nothing crazy detailed. And being able to be hands-on and like it forces you to really know, okay, this is what's here. This is how it moves the body. This is where this tendon is. This is palpation-wise. This is what this feels like. But yeah, I think you think early on, what are you saying? That you're making this real structural change to tissue?
Yeah, and now we know, I can't tell you like, you're in school and it's like, oh, like if you do deep tissue work, and you can tell me where your thoughts lie on this too. It'll be like, oh, you're like breaking up scar tissue. And like now we know we're like, no one is fucking breaking up scar tissue when they like massage you.
100%.
It takes, you could tell I'm a numbers person, but I'm like, it's something like 2,000 pounds of pressure to deform your IT band. 1%. 1%.
Yes, of specific pressure in a specific direction.
Yeah. So no one is freaking breaking up your IT band tightness, or no one is breaking up your scar tissue. Your knee, you had surgery a year ago and you never bent your knee past 90 degrees, and now you're coming to me being like, hey, can you Graston me? And like, I'm like, no, I'm not, I can't break. I don't know who told you I could break up scar tissue.
If I could break up scar tissue, I'd be so fucking rich right now.
Totally. So it's hard too, right? Because in the clinical setting, and you got to kind of read your patient. Who cares for you to explain to them like why you're doing this?
Yes.
I would love everyone to like understand, but not everyone does.
They just want to feel better.
They just want to feel better. So I always say manual, and you also too, it's a fine line because you always get stuck with that patient that's like, oh my God, whatever you did to me made me feel so good. And I'm like, okay. And I even say to them straight up, I'm like, I love that you think that, but I'm telling you right now, like what I did to you, all it did is change like the patterning in your brain.
Yes.
So basically you have things called mechanoreceptors at the cell level, right? And your mechanoreceptors sense vibration, touch, temperature, basically input, and that goes to your brain. And also pain is on these fibers that go to your brain. And your brain, actually, this is a good, like when people wonder, like, what does stim do? This is a great, like, example of like, this is what stim does. So it goes to your brain gets that signal. Normally it's getting a pain signal, right? Like, this is bothering me. And now it feels a different signal, like, oh, I'm feeling vibration. Like, oh, I'm feeling this. And then it sends a signal back down that pathway. And you can see a huge change in tissue tension or a decrease in tone from what you did. So when we do manual, it's not like I sit there being like, I'm just doing this to make this person think I'm making them feel better. Do I notice an immediate improvement in something? Yes. But is it because I structurally broke something up or did this to do this? No, it was more a release and tension in their nervous system that allowed you to gain that tissue mobility. And then I tell people, then you need to utilize it, because
Right.
people will come in and say, oh, you'll do a muscle energy technique on the low back, works fantastically. And I tell people, I'm not putting anything back in alignment. And then what happens is, if we don't hold this in place, you're going to leave and you're going to come back and you're going to say, I need you to do that again. And it's like, well, what are you going to do? Use me for the rest of your life to
Right.
get some muscles
Yeah,
to stabilize around your pelvis?
This is why you foam roll pre-session. Like, let's decrease tone in areas we need to.
Exactly, yep.
Open up this little window where you now have a chance to move better. But now we got to cement it.
And then you gotta utilize it.
and
Yeah.
move better through those ranges.
Yeah, so we use manual therapy a lot, but well, and I should say, when I say we use it a lot, I mean, it's included in a lot of our patients, but our patients are usually there for 60, 75 minutes easily, sometimes longer. Like, our athletes end up being there longer. And we're not super modality heavy, because that's not going to create the changes.
No,
right?
and I especially don't like passive treatments for the younger population too. It's like you gotta take just for them psychologically. You have to rely on yourself and learn tools how you can help yourself, and not rely on me to get you better. But also, like, that's what's going to make more lasting change than passive treatments like manual therapy, like stim, like heat, like ice.
Yeah, and they all have their time and place. And if someone's in like an insane amount, like if we use neuromuscular electric stim a lot on our post-op knees, especially like ACLs, total knees, anything like that. But actual stim to, kind of like decrease your pain. I tell people, I'm like, okay, if I'm putting this on you, it is because you're kind of in such a like heightened state of pain that I'm like, I got nothing else left. You know what I mean? I got to kind of tone it down a little bit. So a lot of times we'll have patients coming in saying like, oh, are you going to ultrasound me? Or, oh, you're going to do this? And then you have to kind of just take the time to explain to them like, okay, this is why I'm going to do this, or this is why I'm not going to do this.
Yeah, I think a lot of us start, right, because you do your schooling, you do your heavy science course load in school. So your brain is just kind of pre-built to be really mechanical, like really biomechanical.
Yep,
do you know what I mean?
Totally.
So you go into the field as like a young 20-year-old and you're like, I know it all. I understand biomechanics. I'm going to fix everything. I'm going to explain it to you. And then you start working with real people. And at some point, if you're going to make it, you realize like biomechanics is like one little piece of the pie, but so is their psychology and their nervous system and how they feel about themselves. And it's just like there's so many other variables. Like, I don't think I got lucky because I met an acupuncturist, this guy Brendan Carney, when I was in Boston. And he taught at Harvard, and he was really biomechanical, but he went to acupuncture school. So he had this whole Eastern medicine side of him as well. And he blended the two so perfectly, like giving, scientific explanations to ways things are done in terms of Chinese medicine. And I was like, dude, this is cool. Like, he's looking at the whole person. He's using all these different modalities. That kind of got me down like the pain science rabbit hole. Like, I feel like I went from all biomechanical to too far in the pain science realm, and then kind of shifted my way back to the middle.
Yeah, I think whenever you learn something new, right, your brain immediately is like, oh yeah, that's like the ticket to everything. And then you're like, okay, I got to kind of reel it back in a little bit.
Yeah, and bring it back in. Yeah, but then not relying on somebody else. How much do you work with chiropractors?
A lot. Again, like when appropriate. Shout out to my guy, Mike Mazinas.
Shout out to Mike. Mike's
Yeah.
great. And Jenny will shout them out.
Yeah. So I kind of connected with Mike a long time ago. One of his friends, when they were at a different chiro clinic, I got to know him pretty well through a patient. He introduced me to Mike. Mike went to his current spot, and we have such great results when we like send patients back and forth to each other. And I think I kind of tell people, I'm like, once you meet us, you'll understand. People always say like, yeah, you guys are kind of like the same, but different. Like, our thought process is very similar, but he's a chiro, I'm a PT, and we just blend it nicely together. Yeah. So we refer out to chiro a lot.
Yeah, he's awesome. But I see some who are just like way too mechanical. Oh, like your rib is out. This is out of alignment. And I'm like, how can you really tell? Like, am I wrong? Like, are your palpation skills that good? Is your eye that good?
Mine aren't.
Mine aren't either. But I'm like, is it even possible? Because I'm like, no way.
I know. I think no way too. And then you'll have someone that says this and that. But again, we know like a manipulation, right? A high velocity thrust, like you're not just globally acting on one tissue structure, right? It's a whole body response that happens, similar to all the pain science stuff. yeah, I think for some people it works. Some people, like you said, they go to a chiro. I'll sometimes get a patient who's like, I love my chiropractor. I've been going 3 times a week for 3 years. I'm like, oh, okay. Like, what's that been doing for you then?
Right. I guess it just depends on the practitioner. That's all.
Yeah. Like everything though, right?
Yeah.
Yeah.
Yeah, that's real.
Yeah.
So when your model, your business model at work, it's insurance based, right?
Yeah, we do insurance based, and then we're a pretty higher functioning clinic, PT clinic, I would say. I think it's not anything aside from just location,
Right.
where we're located, and the type of clients that we get. So because of the insurance game is getting harder and harder, we do cash based model if they run out of insurance.
What's making it harder right now?
More and more insurance companies are basically dictating how many PT sessions you can have, and they base it off of these horrible questionnaires that like you learn about in school, and they're used, and you have to fill it out. I don't know, did you ever fill one out for your Achilles at the doctor's? Like,
Nope.
What you can do, can't do? Yeah. So if you ever fill out these questionnaires, and you got to kind of play the game a little bit, because they'll be like, oh, the person scored this high on this questionnaire, they get 4 PT visits, and you're like,
Oh.
4 PT
So it's like
visits?
this subjective questionnaire.
Oh, totally. And then some of them care about pain, but also like we were talking about, if you have like a Achilles tendinopathy from running, you probably don't have pain in your day-to-day life, and you have some pain running, right? So that's getting harder and harder to dictate. I fight with insurance companies all the time. I don't think I'll ever stop.
I don't
yelling
even
at
know
them.
how many visits I had supposed to have. I think it was some like 6 months and like probably twice a week or something like that I was going to be able to be prescribed for, but I did PT for almost a full year. Like, 'cause even after I went back to play, I was still doing it once a week.
Yeah, and that's where I think our profession needs to get better at like showing how important we are in that late phase of rehab. The one insurance company that I call them all the time, because I'm just like, I don't care. I'm going to call them and I'm going to beg them and then we're wasting our time, right?
So, you must be like, I could be doing so many other things right now.
This is why I don't ever eat lunch or take a lunch or get a break, whatever. But so, you call these insurance companies, and basically a lot of them are like, we don't care about recreational activities or sports. That's kind of what it comes down to.
Mm-hmm.
So you can get good at playing the game a little bit, because we know these insurance companies, and right off the rip, you can kind of tell the person who's filling out that form, like, hey, listen, don't be an overachiever. You know what I mean? And we kind of keep it simple, but just don't be an overachiever, and how you do things. But yeah,
Be
it's
an
crazy.
underachiever.
Yeah, be an underachiever. That's right. Are
It's the
you
only
sure?
are you sure? I
Are
don't think you can do that.
Are you sure you don't have pain going down the stairs? So it's a little bit of that, and that's why then when insurance boots them off, we have to use that. And then there's other insurance companies that are still great. CDPHP, love them, no issues, don't have to. You know what I mean? Like, good, you're rolling with PT.
So it depends on the company.
It totally depends on the company. It's funny though. A state employee, the insurance company that they have to have, is one of the ones we have the most issues with. And our most recent battle with them is we have a state trooper, right? A state trooper who has to be able to like
to help our state.
Patellar tendon repair. So this is, again, a pretty lengthy rehab process, I would say. Minimum 9 months. Someone else also possibly upwards of a year. At the 4-month mark, they're like, how are they doing? Are they behind? Are they not coming? No, but like he had a patellar tendon graft or a patellar tendon repair. Like, this is where we're at. Oh, we don't cover return to work. And I'm like, but they work for the state. You are forcing them to have this insurance. What do you mean you don't cover return to work?
This guy keeps people safe in our state.
Yeah, he's got to be able to hop over a fence and chase his person.
Turn to work, because that's where you got to pay for everything in life.
Let's be productive and don't have me rant about New York State.
Rant about that.
Yeah, so
it's more just the fact that like you were saying with like they don't take into account sport or anything like that. I didn't realize as much until I went through my rehab. Like, it was basically like the bare minimum for being able to just like live an everyday life. Like, I wouldn't have been able to play football still and whatnot if I just did the 6 months.
No,
it wouldn't have happened. I got back to the field pretty quickly, but it still would have needed at least 2 more months.
Do you ever feel like overwhelmed in your day-to-day in terms of how many people you see and not being able to connect and build rapport with people the way you want? Because you're so good at it. Like, you do a great job. I'm just curious if you ever feel like that.
It depends. Yeah, times that, obviously, I'm not going to lie. There's days where you're like, okay, whoa. And it kind of ebbs and flows based on time of the day, who's coming in. This person showed up 30 minutes late to their appointment. So I'm never going to say, oh, no, I never feel overwhelmed. But I also think some of it comes from, like, I just care so much that I can't like shut it off. You know, like you've known this about me for years and years and years. To me, quality of how you do an exercise is so, so important to me that I can confidently say I don't have patients just like, oh, go do your thing over there and I'll check in afterwards and look at them doing it with horrible form. Our clinic design is, I designed it when we moved into our space to be very open in order to be able to see. Because unfortunately, the way the insurance model works, our reimbursement rate, and I'll tell patients this when they're like, why can't I be one-on-one? I'm like, the reimbursement rate that we get from insurance companies is so low that we can't. Like, we literally could not be in business if we just had one person per hour. So would I love if you could be cash-based route, if every PT could be cash-based route? Yes. But the cost of that is so much more that it's dipping into accessibility a little bit. And then I start to be like, oh gosh, I love that I can be so accessible to so many people.
That's like here. I mean, we're a cash-based business. We don't accept insurance, and they don't cover any types of training. They'll give CDPHP does reimbursement. I'm sure others do as well.
The only thing I could think of is for what's it called? Silver sneakers thing.
Oh yeah.
That's the only thing
like
I could
Medicare.
think of.
Yep. Yeah.
Right. But I'm just
But
thinking.
you gotta be old for that.
Yeah.
I'm just thinking because I've worked in like semi-private settings like we are here, but also one-on-one settings. And I like the semi-private because it's smaller group. We can have custom programs. We can cater to your need, but also it makes it more affordable and accessible for people, right? Instead of somebody paying, let's say 125, 150 an hour, I can break that up between 5 people, get the same money, if not more money. And I'm helping more people and you're paying less and getting more sessions in. But sometimes I'll have a day where, we have a full group, I have somebody in, and I go, man, I need to spend so much more time with this person. And it's tough.
Yeah.
And the day ends and I go, shit, man, like, did I just do them a disservice because I could not check in as much as they needed? Yeah.
And that, again, I think, any health professional that cares, like that does pop in your head. And then I think you're just trying to find those pockets of like, okay, where can I see this person? Again, it's why I probably never take a lunch because I'll say to this person, I'm like, okay, hey, I just need you to come at after my lunch when no one else is here. Can you come last patient before my lunch? Can you come at this time? Again, there's no like quota of patients, like you have to see this many patients per week to like make your salary. That doesn't exist. So if we have a patient that's more complex, we can easily be like, we need them in a longer time block. So we have like at least 30 minutes, maybe 45, like one-on-one with that person to do a little bit more. And I think those early sessions do a lot. Like I said, our evaluations are a full hour. Mine will tend to roll over that. It's funny. I always thought like the longer I'm a PT, the quicker I'd get at them. And I think it's almost like the opposite. It's like the more I want to pack so much into that like first piece,
education and like building that connection is so huge early on because that's going to set you up for success in future sessions. And for us, allow us to train you more efficiently in a group setting if we spent better, more quality time early on.
Right, because you're getting that whole picture of the person, right? So you can kind of like piece, and I even say that then I'm like, this pretty much, I'm right now creating my whole plan for you based off today. Because I think, and this is funny too, I think the general population thinks like, I have knee pain. What should I do for it? And I'm like, okay, are you ready for 75 follow-up questions? This happens with friends and family all the time. I'm like, okay, you're going to have to FaceTime me. Okay, you're going to take a picture. Okay, how does this feel? You have so many questions because I'm like, it's not cookie cutter. Like, and if you've ever had that experience with physical therapy, I'm sorry, it should never be that way. Like, not even the same diagnosis, like an ACL, for example. If you're like, oh, what do you start out with? It's like, yeah, they're all going to end up doing similar stuff, but it's like you still have to evaluate that person from the get-go and then design a plan that's like specific to them. So I always say that first visit, that's when I'm coming up with my plan. So we tried, most of the time patients stay with the same therapist, but it depends on scheduling, availability, what time that person needs to come in. I work late 2 days, right? If they can't come in those 2 days but need after work, they're going to see a coworker. And I'm like, listen, they will know everything based off today because we lay it all out in this nice, fluid plan. And you guys do the same thing, right?
Yeah, I think that's big to be able to gather the info, but then to relay it to your colleagues. Because, like realistically, like for this, I'm sure for your practice and for our business keep growing, like we all have our own skill sets. We have to be able to assess, be able to lay out a plan, be able to inform all the other coaches the plan and why things are the way they are. And then everybody has to be able to execute it. Because if not, like this business can't grow because like I got to go home every once in a while and Paul has to go home and this place still has to run. So it's
you
like
have to start to like trust other people and go from there. Who does all the programming? Do you guys all do your own?
We split it. So usually whoever does the person's assessment is who has their program to start. And then it just depends. I don't know, Paul. Sometimes they see it all the way through.
Yeah.
Sometimes it gets passed off.
There's some people I've been programming for 2 years, 3 years now, pretty much since I started here. And then there's some people I've passed off or people I've inherited because of either Mike's board was full or Dan's board was full. And, we try to be able to be versatile in every aspect for all of us. But then there's certain things where, you get a lot of times if there's like a soccer, football, lacrosse player, if it's probably going to go more towards like my schedule, my board and programming. If it's a pitcher in baseball or something like that, it's probably going to go more towards like Dan. And like Mike's kind of a little bit of everything. And then a lot of like the people coming back from like rehab or injury or, something like that where they need
I
more
love the
corrective.
blank slate, new to
I
exercise.
love that. That's my
Maybe
favorite.
a couple injuries, but they're ready to go and they're a blank slate. And that's my favorite.
Yeah, because then you're not undoing bad habits. You're just like, I get to shape you.
And you're not undoing bad psychology with like somebody thinks the gym should be somewhere where they crush themselves and I got to be doing so
Yes.
heavy and so much. That pattern is hard to undo.
Yeah.
Totally.
They look, they go, wait, I'm doing just 3 sets of 8 goblet split squats and TRX rows and half kneeling chops.
Yeah.
Exactly.
Right.
That's what we're doing.
That's what we're starting at.
One of my favorite clients, I think I've mentioned him on here, he came into my office when I was in New York City and had never worked out before. Complete blank slate, no injury history, which was great. And
That's rare. How old were they?
30.
But 30s. Oh,
30s.
That's rare. That's rare.
Uh-huh.
Yeah.
I mean, they weren't, never played sports, nothing like that, like, and whatnot. Long story short was he was one of my favorite clients to train because of that, and I could just kind of be like, all right, you're going to buy into whatever I say. This is great. And 2, he eventually became a trainer himself.
That's
And whatnot.
awesome.
Shout out to my guy Sam. He's great. He still lives down in New York City, but yeah, he ended up becoming a trainer and whatnot. And I was
Because of the impact that you made.
yeah. And
Yeah,
he also was like,
that's so
I see
cool.
how you have changed my life, and I want to be able to do that. And I was
That's amazing.
so it's fun to get those blank slates because you can develop, especially in a one-on-one setting, develop this relationship with them and all this other stuff where you're literally changing their life in a whole different way because they've never done it.
Yeah.
Yeah, the blank slate is nice because you just want to set them up to it's easier to be like, hey, here's how we're going to set you up. This is how you train. And to them, that's always how you train.
Yeah.
It's not shifting this mindset of how you train.
Yeah. And like you said, undoing bad habits. Yeah.
Yeah, that's real. Shoot, dude. I appreciate you coming on.
Yeah,
Yeah.
man.
This has been great.
I'm surprised we haven't had her on sooner.
Yeah, I don't know. I'm
Yeah.
sorry we haven't. 'cause
Yeah, I know.
just
I
thought
mean,
of it.
Yeah, I know. I do feel a little hurt, but it's okay, Mike.
Don't
Forgive
tell
you.
me that.
No, thank you guys. This has been great.
Yeah, it was fun.
Yeah,
So
not as scary as you thought.
No, like I wasn't. No, I'm gonna blame Dee for this one.
What did she say? Did she make you nervous?
No, she was like, "This is hilarious. I'm gonna tell Mike that you're so nervous to be on the podcast." I was like, "I'm not nervous to be on the podcast. It's just, again, me and you have talked probably the most out of anyone here. And some of these areas, I'm like, oh my God, I could. And I told you this yesterday when I saw, some of the topics and stuff. I'm like, I could talk for, 2 hours about 1/3 of what we went through. You know what I mean? And just go through there. So no, it was good. Just
Dude,
yeah.
I appreciate you. Yeah,
Yeah.
we'll do another. And just in our day to day, I've said this before, but when we connect, it's like a quick phone call. You're probably skipping your lunch and calling me, or
You're probably doing the same.
definitely doing the
Yep.
same, or it's a quick text. I step off the floor, send you a quick text to check in, but everything happens so fast.
Yeah.
It's like this, honestly, probably however long we've been going, probably equals or surpasses how much we've talked
Combined time in 5 years.
during the last 5 years.
Yeah.
100%.
Yeah.
It's a blast. Anything you want to plug before we get off?
No, I mean, we can, like, you shared this. It's Thomas Nicolla Physical Therapy, and we're specifically in the Clifton Park office. We have a great group. Like I said, there's 4 of us there right now. We collaborate. Awesome. Lots of Shen kids, lots of Shen families, very sports specific. Also just like anyone that wants to move better, move without pain, motivated, like we want you. Yeah.
Motivated movers.
I know someone said that. I heard that podcast too, and I was like, I love that. Motivated movers.
Shout out, Pat.
Was it Pat? Okay,
Yes.
I couldn't remember if it was Pat or Evan
was Pat.
or who it was. But
Jeez,
yeah.
good memory, Paul.
Motivated movers.
Stuck in
I
my
love
brain.
it.
Yeah. Hey, you're the best. Thank you, Sam.
Thank you, Mike. Thank
And
you,
we'll
Paul.
catch everyone next time.